Welcome to the next chapter of our YouTube Rad Path channel. Today we'll be talking about the ovary, and I'm going to tell you we got some of the best Rad Path in all the lectures, so this is going to be a good one. Again, my name is Matt Hartman from Pittsburgh, PA. Most of the lectures can be found on the ACR building blocks. This is going to be the one exception. This is such a new lecture, it hasn't made it up there, but be checking for it if you want to look at the whole lecture. But I know most of you are watching these lectures at 2 times the speed, but feel free to pause it anytime, go back. And like I said, we'll have this uploaded shortly. Again, the Anki RadPath deck is available. For instructions on how to access it, go to the About section of our YouTube channel. So let's dive right in and let's start with a real RadPath case. We're getting lots of visiting students to take the RadPath course. So I think our reputation has been expanding, and anyone out there that wants to take the course, rotate with us. We'd love to have you. But we get a ton of great GYN pathology. And we'll start with this one. This was about a 55-year-old female. Belly pain, so stones, bones, mass, and gas. Maybe a mass here. We'll see. We'll go to the truth machine, which is the CT scan. And what do you know? A big mass. We'll talk about how to work these up, but one of the big questions is solid versus cystic. Put Hounsfield units, you get about 10. So we're thinking cystic. Here's the coronal. You can see it's causing big time mass effect on the bowel. The bowel is being displaced by this large cystic mass. It's going to be a surgical lesion. We can come up with a differential. We'll do that a little bit later. But we're thinking something ovarian. We're thinking something cystic. It looks like a watermelon here. And we have a great movie of this being sliced open by the pathologist. And this is what it looks like when it's all deflated. Still some locules and septations in there. This ended up being a mucinous cystadenoma. We'll see a very similar example. These all look the same. So let's dive right into the lecture. So when we're imaging the ovaries, we can do it several ways. Ultrasound is going to be the quickest, no radiation. CT, quick. There is radiation, get a good sense of solid versus cystic. An MRI, it's going to be more expensive, take longer, no radiation, that's always a plus, and sometimes provides the best characterization of ovarian lesions when we're challenged, when we can't figure out between ultrasound and CT. One of the first questions you have to ask yourself when you see something in the adnexa is it coming within the ovary? Is it ovarian, or is it extra ovarian? And some things you can use are the claw sign, the location. Sometimes it's pretty obvious, sometimes it's hard. Our next thing is solid versus cystic. If you haven't watched the first RadPath lecture, I highly recommend you do that. We spend a lot of time talking about solid versus cystic, but we will review it here. On ultrasound, we are looking for anechoic fluid. Now, this is not a simple cyst. There's lots of septations, so we'll call this cystic. On CT, remember, water is 0 Hounsfield units, less than 20, so this is cystic. And on MRI, cystic lesions will be T2 bright. This is T2. It's pretty bright. Not a simple cyst. We got some septations in here. So again, is it a simple cyst or cystic? Go. Our next question is the patient pre or postmenopausal. This will greatly change our differential. If they're premenopausal, most of the lesions are going to be benign. It might be a little bit large, and we'll re-image in 6 to 8 weeks, see if it resolves. If they're postmenopausal, we are going to be a lot more worried, especially if it's solid. So these are the ACR appropriateness criteria. Hopefully everyone's familiar with this. So suspected adnexal mass. This is non-pregnant, reproductive age, and it says start with the ultrasound. If they're postmenopausal, again, start with the ultrasound. So ultrasound is usually our workhorse for working up these adnexal masses. So let's talk about some benign lesions first. So some definitions. Follicle, less than 1 centimeter. Dominant follicle, 1 to 2 centimeters. And anything that's greater than 3 centimeters, we will call a cyst. So here is a simple cyst here, and here's a 1 centimeter follicle. Notice that this is actually in the ovary. I think this one's pretty easy to tell. Here, this is in the ovary as well. You got some parenchyma along the periphery. These are what I call ant minis. You can see these a mile away, and if you've seen it, piece of cake to diagnose it. And if you've never seen it, you're like, what are we looking at? So this is going to be a cystic lesion. A lot of it is anechoic, but we have a bunch of septations. This is a premenopausal female. It sort of looks like a cobweb, lace-like. If you hear those terms, we're thinking hemorrhagic cyst. And these will resolve. If it's a larger one, greater than 5 centimeters, we'll follow that 6 to 8 weeks. This is assuming the patient's not in any pain, there's good Doppler flow. That's how we'll follow that up. Now, how about this one? Now, this one is not a simple cyst. I don't know how well this is projecting, but there are low-level echoes in this. Now, if I didn't tell you any, if I told you this is a guy, you'd say this looks like a testicle. And that's the best description I've found for describing these lesions. This is an endometrioma with some low-level echoes. It's not a simple cyst. It doesn't have these lace-like echoes. This is an endometrioma. Sometimes it's hard to distinguish these two. You can always follow in 6 to 8 weeks. A hemorrhagic cyst will resolve. An endometrioma will not resolve. And this is what an endometrioma can look like, the so-called chocolate cyst, for our rad path when we open it up. So normal left ovary and this right ovary, that big cystic mass that sort of looked like a testicle on the ultrasound. So let's talk about some of the tumors. It's important to remember from Pathology 101 how we characterize our ovarian tumor. So we have our epithelial, that will be the majority. We have our germ cell, that's where our teratomas are, our sex cord stromal, and we also have Mets and slash lymphoma. So the so-called Krukenberg tumor, especially if it's bilateral masses, be thinking about that. Lymphoma, we'll get a couple of those each year where we're thinking something else. No one's thinking lymphoma, and it ends up being lymphoma. So I'm telling you, Mets lymphoma for every differential. But this is a real nice depiction of the different types of ovarian neoplasms. So not uncommon. Again, more common in postmenopausal females. So 30% of ovarian masses in postmenopausal female will be malignant. The risk factors, we all know the BRCA. And the workup, again, starting with ultrasound is one of the best ways to work up suspected ovarian pathology. And this is a take-home point: solid adnexal mass, cancer until proven otherwise, especially in the postmenopausal female. So if we've diagnosed ovarian cancer and we are staging it, what are we looking for? Well, one of the big things is remembering the tumor tipping points. How does it spread? So it likes to go follow the blood supply, the para-aortic lymph nodes. Same thing with testicular cancer. Something that is unique to ovarian cancer as opposed to testicular cancer is the omental spread. This is the omental caking. Maybe we'll do a dedicated lecture on omental caking. I have some great rad path cases of that. But this is nice. We gave the oral contrast. This is bowel. This is not bowel. This is solid omentum. Normally the omentum is nice and fatty. This is solid omentum. This is omental cake. And remembering the tumors that like to spread in the omentum, ovarian, colon, stomach, and pancreas would be my top 4. So let's go through some cystic lesions. This looks very similar to our other lesion. Unfortunately, I don't have any movies, but you can sort of imagine this big mass, you pop it, and all this liquid drains out. We look at the CT here. Hopefully everyone can see this as a cystic lesion. It's less than 20 Hounsfield units. It looks the same as the bladder. We want to make sure we don't confuse this with the bladder, but it is causing big time mass effect, displacing the bowel out of the way. Another, I think this was that same case. This is what it looked like grossly. You pop it, and it was all liquid content, maybe a little bit of blood mixed in there. This was a serous cystadenoma. Okay, another patient, a little bit older, 71-year-old, abdominal pain. My mnemonic for reading abdominal radiograph is stones, bones, mass, and gas. Mass is the hardest thing, in my experience, for med students, residents to pick up, but hopefully everyone can see if there's something here, right where the X is, and it's displacing the bowel, pushing it out of the way. We can imagine a big mass here. There's our bowel being displaced. And we get the truth machine, the CT, and we see a big mass. Again, is this solid or cystic? Well, as opposed to the other one, so this is cystic. It's going to be less than 20 Hounsfield units, but the other one was much more simple. This one has a bunch of septations, maybe a little mural nodule there. Again, we're going to have our bladder right there, the X. And grossly, it looks pretty similar to the other one, but we know what's inside. We know it has all these septations, and we're seeing all the septations here when you pop it, multiloculated. And this is going to be a mucinous cystadenoma. So again, our two most common epithelial will be the mucinous and serous. Okay, another patient, 57-year-old female, left adnexal mass. This one's smaller. Again, it looks cystic, so we're thinking cystadenoma, maybe cystadenocarcinoma, if there's a solid component. So we're always thinking, could this be cancer, right? And this is the gross specimen. This is really neat. If you've never had a chance to do it, to watch the pathologist take the gross specimen, they measure it, they're looking for the most suspicious part. This might be a solid nodule on the outside, take a sample of that, do a frozen, and then we're going to pop it. That's always my favorite part. The majority of it is going to be liquid, but we have to be worried about the solid parts on the either on the inside or the outside. And this one ended up being a cystadenofibroma with a fibrous stroma. So a little bit different from our other ones. Again, this is a microscopic diagnosis. And you can read a little bit more about cystadenofibroma. Okay, let's switch to solid lesions. So here's a nice gross specimen. Again, looking at it, it can be hard to tell solid versus cystic. But we have X-ray vision and we can look inside and you're like, hey, that looks like it's going to be more than 20 Hounsfield units. That looks solid to me. And we have our differential for solid lesions, epithelial, germ cell, stromal, and Mets. Remember Krukenberg and lymphoma. And there's our bladder. Don't miss the bladder. And when we take this one out, much different. There's no pop in this. This is all solid. And again, if you take the rad path course, students actually feel this. Get to really get an appreciation for the difference between solid and cystic. And this ended up being a ovarian endometrioid adenocarcinoma. The main point of this slide is just getting a sense of solid versus cystic and how this is different from the other ones. And then our next category, complex. You're like, what are we looking at? You open this up, very heterogeneous. What could this be? So we have the scout film. Again, our mnemonic stones, bones, mass, and gas. Hopefully everyone can appreciate we have a mass here. It's displaced in the bowel. But within this mass, we have some calcifications. Maybe it's a little bit less dense here. So we'll see the truth machine, what this ends up being. These are calcifications. There's our bowel. And here we start with the sagittal. Here's our axial CT. And the thing that strikes me is we got a well-demarcated mass, and I see all different densities. So we're going to have, here's our pelvic mass, there's our bladder, there's our uterus. So this is extrauterine, probably coming from the ovary. Sometimes it can be hard to tell when it's this big, but I'm seeing all different densities here. And here we've got our Hounsfield units. So we got this really bright stuff that is measuring 974 Hounsfield units, lower density stuff. This is negative 70 Hounsfield units. Hey, that's the same as the sub-Q fat. So this is macroscopic fat here. And then we got this lower density, 22 Hounsfield units. I said about 20 is about the cutoff for cystic. So this might be fluidy. So I'm seeing calcium, fat, and fluid. And this ends up being a teratoma, very large, with some teeth and fat. And here's just a review of the Hounsfield units. And showing this on a different patient, but on MRI. Hopefully you can see the different signal intensities here. I think this was a T2. And just note that's really bright. That's a different gray. We've got the sub-Q fat here. And we are going to do one of my favorite sequences. This is our axial T2. Here we give them an instant liposuction. So hopefully you saw the crash course pelvic MRI. Use this as a stepping stone. So identify this as a T2. And then note the sub-Q fat is dark here, bright there. This is a fat sat, instant liposuction. And we have some areas that are bright here in the teratoma, which when we give them the instant liposuction, that becomes dark or hypointense. So we can say, I think it's easier to tell on the CT there's macroscopic fat, but on here, the MRI, we can definitely confirm there's macroscopic fat here, some cystic fluid component. You're not going to see the calcium that well on the MRI, but we have a strong suspicion this is going to be a teratoma. This is a cool intraoperative picture. You can actually see the hair coming off of it. This is the gross specimen. Again, there's the hair there, some cystic components that they could pop, but this was a teratoma. And here's some information on teratoma. Here's another one sliced open. We always worry about them rupturing, serving as a source of torsion, and then rarely chance of malignant transformation. So let's remember the workup for ovarian lesions. The first thing is deciding, is it ovarian or extra ovarian? Next question, solid or cystic? And then remembering to know the patient's age, be cognizant of the age. Are they pre or postmenopausal? We saw some nice ant minis of the hemorrhagic cysts, the lace-like echoes, the endometrioma, homogeneous or looked like a testicle. And then we saw some great rad path with some cystic lesions and some solid lesions. So our first line imaging is going to be ultrasound. MRI is fantastic for characterizing the lesions. We saw the example with the teratoma where we saw the macroscopic fat in there. CT was great for the surgical planning, that case we saw with the omental caking. Our gyn-onc colleagues will always be correlating with the CA-125 levels. And for surgical planning, having understanding of the rad path basics is going to make you a lot more confident with the understanding what's going on.